Okay, so we got the next lecture is on heart failure. The points that we're going to go over this is we're going to go over what's the definition of heart failure, the different forms of heart failure, different presentations that you may have, and then ultimately the treatment plans that you have with these kind of diseases. What heart failure is basically the inability for the actual heart, which is the main etiology for not developing enough forward cardiac output. Basically, the heart's unable to pump blood forward at a sufficient rate to meet the metabolic demands of the body. There's also one that calls backward failure, and that's inadequate cardiac output in which the filling pressures are abnormally high for forward cardiac flow to take place. This tends to be a problem that you see when your patients are coming off cardiopulmonary bypass. You tend to get more of a backward flow failure problem, and you get a decrease in ventricular compliance. And because of that reason, patients require higher volumes to achieve this. We actually get the same amount of volume in. It takes more pressure to get to that point. So these people have an elevations in LV, EDB, as well as it increases in PA occlusion pressures. We call these forms of heart failure, sometimes in textbooks, as either right heart failure or left heart failure. And let's go through each one of them specifically. Left heart failure is usually known as congestive heart failure because it presents completely differently than right heart failure. The reason it's called congestive heart failure is because it congests the lungs. Right heart failure does not congest the lungs. Okay? In other words, you don't get pulmonary edema with right heart failure. You get only pulmonary edema from left ventricular failure. With congestive heart failure, which is left ventricular failure, you get impaired left ventricular myocardial contractility. It could be from ischemic heart disease or cardiomyopathies, which we'll talk in the next hour. It could be also from systemic hypertension. It can actually induce an acute left ventricular heart failure. Patients that have cardiac valve abnormalities, usually at the left ventricle, such as AS, AI, mitral stenosis, or MR, may actually develop left ventricular heart failure. And then, of course, different forms of congenital heart disease, such as either ASDs, VSDs, or some kind of valvular problem associated with congenital heart disease can induce a left ventricular heart failure. When you have isolated right ventricular heart failure, it's because of impaired right ventricular myocardial contractility. It could be from ischemia, like from RCA disease. It could be also from cardiomyopathies, although most cardiomyopathies tend to be non-selective in the sense that they attack both ventricles at the same time. You may have actually an air embolus, which is you can actually get right ventricular failure from that because the air lodges into the right ventricle, and then the air cannot escape, and as a consequence, the person's right-sided heart fails, and the left side fails as a consequence, but this person develops dry lungs. And the other thing that can actually increase right ventricular systolic afterload would be things like pulmonary hypertension, which will then develop what's called cor pulmonale, which will be talked later on in pulmonary diseases. But cor pulmonale is a form of right heart failure from elevated PA pressures. And then you also have your right-sided cardiac valve abnormalities, pulmonic stenosis, pulmonic insufficiency, which is usually pretty rare, being a major problem. TS and TR can also be present, and some forms of congenital heart disease as well. But congestive heart failure, which is basically left ventricular failure, is the most common DRG diagnosis in the United States. It's actually the most common cause of RV failure is actually left ventricular failure. So usually because the ventricles are in series, when the left ventricle fails, eventually the right ventricle will fail. Okay? So it's really the most important contributor of postoperative cardiac complications because the left ventricle will show signs of ischemia more rapidly than the right ventricle most of the time, and also increasing volumes and switching from positive pressure ventilation to spontaneous breathing can put people in failure as well. And I'll talk about that a little later on. The hallmarks of left ventricular failure is, of course, the decreased cardiac output. This leads to a decrease in organ perfusion, which are the most important ones of the brain and the kidneys. Yes, ma'am. DRG is diagnostic-related groups. It's what we use when we admit people into the hospitals as to what are indicators for why that person got admitted into the hospital. Or then we then charge based on that as well. Anyways, decreased cardiac output leads to decreased organ perfusion. Decreased renal perfusion will lead to hormonal releases of renin, and renin will then activate, leading to an increase in angiotensinogen to angiotensin 1. Angiotensin 1 then converts into angiotensin 2, which then activates aldosterone, causing more sodium retention, more water retention, and making the situation from bad already worse. It also increases the levels of angiotensin 2, which causes vasoconstriction, which increases the overall sympathetic tone of the body, which also can make the congestive heart failure even worse. Eventually, with these lack of organ perfusion, will develop metabolic acidosis. So usually it's an indicator that you're not perfusing adequately, so the person is in a form of shock. Eventually, what you end up seeing is that the left ventricle begins to dilate, and as a consequence, you can see an increase in left ventricular end-diastolic pressure and volume. You see also, as a consequence of back pressure, the valve begins to leak, and you will develop increases in PA occlusion pressure, PA pressures as well increase. The person will develop early signs under anesthesia. Bronchospasm will appear, will be diffuse wheezing, and if you don't pick it up, because you don't understand what pulmonary edema is from, pulmonary edema is a two-step process. The first stage process, interstitial edema, which will give you bronchial edema to take place, and the person will start to wheeze. And then the second stage will be alveolar edema. Okay, you get eventual decreases in PaO2 and saturation. So that's a hallmark of congestive heart failure. As the saturations begin to fall, which is oxygen becomes limited in the bloodstream, which then accelerates ischemic disease if you're having it. And then eventually you get pulmonary edema. Excuse me for 1 second. What you see as a physiologic mechanisms of adaptation is that several things will happen. Frank Starling's relationship will show definite signs of decreasing in contractility for the same filling pressures, which I'll show you here in the next slides. These are all sort of precursors to the next few slides that we'll see. The inotropic states decrease, the afterload is increased. Heart rate is also increased due to sympathetic overstimulation. And the person will then progress into myocardial hypertrophy and eventual dilation, which that's a bad sign because myocardial hypertrophy is increasing the person's myocardial workload, and dilation eventually is basically something that's not reversible. So one of the things that we're trying to do is prevent that from happening. The autonomic nervous system is activated because of inadequate perfusion. The sympathetic nervous system becomes activated, releasing higher levels of norepinephrine and epinephrine into the bloodstream, which then begins to bathe the heart with this increasing levels of norepinephrine and epinephrine. Downside to that is that these are receptor-driven hormones that are being actually pushed into the bloodstream. And what eventually happens in the heart is that the actual receptor numbers begin to diminish. They actually downregulate themselves, which then aggravates the situation worse because you lose contractility, and as a consequence, the heart begins to inadequate have contractility, lower cardiac output, and then the autonomic nervous system activates even more. Eventually, you get this continuous bathing of epinephrine in the bloodstream, burning out the heart receptors overall in time. And then when you have to later on treat these people with some dose of medication like epinephrine and norepinephrine, it doesn't seem to work. And that's usually a very close indicator to you that you have severe downregulation of the actual receptors. The other hormonal humoral-mediated responses is renin-angiotensin, vasopressin, circulating catecholamines, we just talked about, and the natriuretic peptides are also being released, which I'll show you that in a minute. The Frank-Starling curve, which is this green line, is a normal, and you can see the patient that develops congestive heart failure for the same amount of volume. The person's ability to eject and form a cardiac output is significantly diminished. So the actual Frank-Starling relationship is dropping. Way the person compensates for it is a slide outwards with higher volumes to be able to deliver the same cardiac output that a person with half that volume. So you can see in this individual the actual preload curve, the pressure volume curve. The person in the normal is in the control loop and then slides out more laterally, which you can see a loss of contractility and the loss of contractility line as well. What you see is the inotropic state is diminished. Okay, you got the velocity of contraction, which is this in figure 3, shows the decrease in inotropy because of decrease in muscle fiber shortening velocity. And so you get a Vmax that's diminished, and the decreased inotropic state leads to congestive heart failure, which can make it worse by volatile anesthetics, which actually worsen the inotropic state as well. The volatile anesthetics are myocardial depressants to a certain degree because they do weaken muscle activity. So as a consequence, the inotropic state usually diminishes with most volatile anesthetics. What you see, this example here, this is a typical person in the black line for somebody who is under normal conditions. And then the dashed black line is an indicator of dropping in contractility. So you see that the stroke volume is diminishing, and you see a residual increase in dead volume inside the left ventricle. And eventually, this person will eventually slide laterally more and more towards the failure curve over time because the ventricle begins to continue to have a higher and higher preload. Eventually, once you get beyond the Starling curve, this line right here, where you get over the failure curve, then you get a very significant alteration in your compliance, but in your contractility diminishes even more rapidly, and now you're in more trouble. What afterload will do in this individual is, unfortunately, will increase inappropriately because of increase in sympathetic tone. What that basically does, and this is the sliding out that I was explaining to you before. It goes from this normal curve in here, it goes out to the lateral one. You can see how the contractility is dropped off in that individual. But even more of a concern is you see the afterload is actually increased, and that even diminishes even more your actual stroke volume, which increases the risk of developing further congestive heart failure. So afterload is one of those things that you really want to diminish as much as possible with congestive heart failure. The actual treatment plan usually is to put these people on ACE inhibitors and drop their systolic pressure to around 100. So you diminish that afterload effect as much as possible. Heart rate on congestive heart failure, unfortunately, the compensatory mechanism of dropping your stroke volume is elevations in heart rate. Elevations in heart rate can be okay in the sense that up to around 120 heart rate, the actual ventricle empties more efficiently. But after above 120 heart rate for most individuals, then the actual preload point, which is down here, will actually begin to shift this way. So initially the heart rate, then somebody that's in failure, shifting their heart rate increases a little bit, will shift the preload point downward, which improves puts them out of the failure point. But once you get above 120 heart rate, it actually shifts in the wrong direction, and that person can actually progressively get worse in their failure. One of the things that I'm really careful about is if I see a patient that's in active failure, I don't want them bradycardic. They're to the point that they're now on the active, in the sense that they're developing pulmonary edema. They need a more rapid heart rate, okay? Because you're not going to get the contractility to increase that much more at that point. So you want the preload to fall a little bit. So if that person's already at 55 heart rate, you want to let that beta blocker wear off a little bit, and as the heart rate increases, the actual preload point will diminish and hopefully shift them out of the failure portion of the curve, and the person should improve. It is very dangerous to put somebody that's in active congestive heart failure on beta blocker. It's really not a good idea, okay? But if their person is in chronic CHF and now is stable and not having any symptoms of pulmonary edema or anything like that, it's actually a wise thing to put them on beta blockers, because what you're doing is it's a different form of therapy. You've got to remember what you're using it for. When you're giving beta blockers to somebody, you're decreasing their contractility. You're also decreasing their heart rate, which both decrease metabolic workload. So you're working more on the arm of load. How much workload does that person have to have? And you're diminishing it. But if you're already in active failure and you push down the contractility and push down the heart rate, you may worsen the acute congestive heart failure very rapidly. And that's one thing I think a lot of people don't understand. And I've seen people that are in actual full-blown congestive heart failure. Somebody decides that I'm going to give Esmol because I think it's a good idea. I think it's not kind of a good idea. One of the things that will happen over time is the ventricle will hypertrophy initially. That's the early compensation to pressure overload syndromes like aortic stenosis or chronic hypertension. And what the consequence will be is that the actual preload curve will shift upwards and to the left on your screen. This is an indicator of left a decreased left ventricular compliance. So what that basically means is that for that heart to be at the same amount of volume, this is volume this way, okay, for this person to have the same amount of volume in the heart, what happens to their pressures in the left ventricle? The LVEDP is actually increasing with hypertrophy. The reason that's such an issue is because when you have your coronary perfusion pressure equation, that's ADP minus your left ventricular end diastolic pressure. So if this number is increasing, then this number is going to fall. And then you push that person into ischemia. And that's the concern. Okay? Now what happens if you wait too much longer? If you wait too long, the person may then eventually dilate. Okay? The dilation occurs in things like in mitral regurg or aortic insufficiency earlier, and it's indication of increased ventricular compliance. It's usually also indicating to you that the myocardium is losing mass, which is not good, and it begins to dilate. Okay, so what you see in this situation is a curve shifts downwards and away. Okay, and what that person will do to have adequate volume, okay, is that they'll continue to shift the volume upwards up the curve so they're at the same pressure. So these individuals, even though they appear to have a normal PA occlusion pressure or a normal left ventricular end diastolic pressure, their volume is almost doubled a lot of times. So these people will begin to have very large hearts with appearance of on your PA occlusion pressure that everything's okay. You can actually have somebody with an EF of 15% with a PA occlusion pressure that's 12. And you're going like, why? And the reason being is because the ventricle has changed its compliance. It's a nightmare to take care of because if they get into trouble, there's very little place to run. Okay? You can push them into a failure very easily because for the same amount of pressure, look at where they were at before, and this is a failure curve. Okay? I'm almost at the failure point right now. So I give them a little extra volume, heart expands, boom, they fail on the spot. Okay? So that's why you sometimes will see that the person appears to be okay when you're doing the swan and everything looks okay, but then you give them a little extra volume and all of a sudden they're in failure. And that's usually will indicate to you that the person's ventricle is acting more like the right side, and once you fill the volume up to a certain point, it rapidly changes pressure and causes the person to go into failure. Yes, sir? No, it happens over time. Hypertrophy is the first step. Usually the heart goes through, and the actual treatment plan now is to prevent the heart to go into this dilation state. There's new chemical mediators that we are finding out that actually are causing this conversion from hypertrophy to dilation. Most of the time, hypertrophy is a cause and effect of elevated systolic blood pressure. Okay, so the heart begins to see a higher afterload effect, so it begins to hypertrophy. But what happens with time, the heart begins to send, releases certain kinds of chemicals into the bloodstream, which then tells the heart to dilate. Okay? Well, we're now finding out that ACE inhibitors will actually stop that from happening. ACE inhibitors, for some reason, are able to not only drop your systolic pressure, but actually inhibit the chemical mediators that cause the person to convert into a increased volume state, which is what you don't want to have. Once you get it to this point, guess what? You can't fix it. Okay, so that's where you don't want to be. If you're in hypertrophy, if you get the heart better, in other words, you put in new coronaries, you get them work, stent them, and everything reverses, then that person will come back to normal. So you have a chance still. But once you get into the dilated state, it's a bad place to be. What we usually do is we'll put LVADs in people, which is left ventricular assist devices, and then get them ready to go to the next step, which is transplantation. Right. Right. And that's the thing that's kind of tricky for students to learn is that congestive heart failure is a progressive disease. Okay? The reason that we're seeing so much death with it is because the population is doing what? It's aging. Okay, so as you age, the normal pathophysiology of this is to go into this hypertrophy, then to dilation, and then once you get to dilation, it's very quickly after that, 6 months to 2 years later, you're dead. Okay, so it rapidly progresses, but during that initial phase, which is maybe 4 or 5 years, where you're developing hypertrophy, then you can, if you can prevent that from switching over, then you can keep that person around longer and longer and longer, which means that you're stacking the older people with disease, keeping them healthier for longer periods of time, but eventually kills you eventually. There's some ways going to kill you, let's put it that way. It just depends on what your fate is going to be for that day. Okay? If it's congestive heart failure, the good thing is we got a lot more treatments, and we're getting better at it, so we can take care of it, but it doesn't mean that you're going to magically be able to take away the disease. All you're doing is you're ameliorating some of the symptoms, and hopefully you can get them through surgery when you have these kind of problems. But the reason you have to understand this is when you put these people to sleep, if they're on the higher end, they're already on the dilated state, you should know in your mind, these people are really sick. These are the people that are most at risk for dying on the table. The hypertrophy has its own risk of developing ischemia if I work them too hard, but usually they're still got a little bit of time before they got a problem that's severe. They've still got problems, but not to the level of dilated ones. Okay? The danger of dilated cardiomyopathies, dilated congestive heart failure, is that they respond positively to positive pressure. Because when you put positive pressure, what happens to the ventricle? It pushes them down, and now you're on a little bit better portion of the curve, so you're actually ejecting here. But the problem is when you take them off. If you take them off the positive pressure, all of a sudden now they shift rather quickly back up this curve, and they could be on this side and put them into failure. Okay? Now, the hemodynamic parameters that you see with congestive heart failure is that you get cardiac output decreases, your EF is down. Remember, your normal volume 60 cc's. We're looking at these individuals have 20 to 40 cc's. That's about it. Some of them put out as low as 10 cc's or 15 cc's per heartbeat. That's when their EFs are down to 10, 15%. The lowest I've ever seen somebody in failure was 5%, and they're still walking around. Not walking very fast, but they were still walking around. And they had biventricular pacing and everything else in place, so that's the only reason they could do it. If they had 5% with not biventricular pacing, no way. They weren't going to make it. So what you see as an end result is you see all these releases of all these different chemical mediators. So congestive heart failure becomes this kind of milieu of a soup that things are being thrown into your bloodstream that have different effects. That some of them are negative, some of them are positive. And what we're trying to figure out is where in this pathway can we cut the negatives out and still sort of keep these people going. So there's a lot of chemical research in this area because there's a lot of old people and a lot of people that have money are older, so there's going to be a lot of research in this area. Okay? And it's going to continue in this area, if I can tell you right now. Imagine, just look at Dick Cheney. Dick Cheney had multiple infarcts. He's had like 8 or 10 infarcts. Okay? And I think I told you in that class before that they put an LVAD in him. Okay, which that's maybe $1 million operation. And then they put another thing, which is now he's got a target transplant. But now he's cured. So he's going to have hopefully another 15, 20 years of function. So you can see people that actually, the medicine that we have has tremendous capability of doing what it does. The question is, how much can we afford as a population? Can we afford to keep doing this? And that's a very big question. A lot of countries in Europe basically have answered no. And if you ask the system in Sweden, which they actually have per capita costs $300 per person per year for medical costs, but they have no transplants at all, period. They don't do any. And their dialysis is limited to 55 or under. And if you're over 55, you have to pay for your own. So there's not many people on dialysis of consequence. So that's considered health care. That's really called well care. You can give aspirin to a lot of people for $300 a year. What we're talking about is health care here is just costing a lot of money. These medicines are very expensive. They're not cheap. Imagine all the research that's gone into to understand this. When I was a medical student, 1/10 of this was understood. So medicine is still going through a tremendous amount of changes. And who knows what it's going to be like in 20 years by the time you guys retire. It'll be completely different than what we have now. Anyways, the other thing that's released into your bloodstream is ANF, which is a atrionatritic factor or an atrionatritic peptide. It's a normal hormone that's released due to atrial dilation. It's an indicator to the body, hey, I'm getting too full here, and I need to stop from taking in any more volume. So what ANP does and BNP will do normally is decreases renin production, decreases aldosterone production, which then increases the person's natriuresis and diuresis, decreases blood volume, and decreases blood pressure. That's what should happen. That's a normal. But with a person like this that has a chronic distension of the atrium says to itself, I like 78 degrees. It's my new temperature for my room. So I'm going to live with that. So ANP drops in its levels back to normal levels. And actually sometimes will fall below normal levels. And now the person doesn't have an ANP system, so you don't get this inhibition of the renin system. So this person will then begin to reaccumulate more and more fluid as a consequence. So ANP sort of goes out the window. And I know some people will actually tell you, well, ANP is a marker of congestive heart failure. And the answer is, in the acute stage, it is, yep, absolutely. But in the chronic state, no. Okay? So ANP will suppress aldosterone and ADH, which then, like I said before, causes decreases in natriuresis and diuresis and decreases in blood volume. You also get active, yes, sir. How long? It depends. Some people's disease progress more rapidly because they have a bigger infarct area or develop a cardiomyopathy where they actually damage more portions of the heart. See, there's many different causes of failure, but what eventually causes that failure is what ends up what we call failure, okay, which is you got cardiomyopathies, you got ischemic problems, you have viruses, all these things can cause failure, okay? But once you get into the failure point, the dependence on how much injury you had in your myocardium and how bad the heart's functioning will then determine the duration of how long these symptoms will last. If somebody gets an acute left main disease, they'll go into acute pulmonary edema, acute left ventricular failure, and die on you within 6 to 8 hours. If you have, let's say, a diagonal disease and you infarct there and then you infarct part of the circumflex, then it'll be more of a gradual progression disease. It'll take up to 20 years before you die from it. Okay, so it really depends on the severity of the presenting symptoms. But it will go rapidly down the phase if you get enough damage. So that's a hard question to answer. What we're talking about is here is more the long-term effects. One of the things that will happen with decreasing cardiac output is you get decreased renal perfusion. And as soon as you do that, you get an increase in renin release because of lack of perfusion. The other thing is activation of the sympathetic nervous system will also increase renin release. Renin will then convert angiotensinogen into angiotensin 1. Angiotensin 1 then goes into angiotensin 2, which then causes vasoconstriction. Angiotensin 2 will then cause activation of the adrenal cortex to release aldosterone. Aldosterone then goes back to the kidney and causes increase in sodium retention, which causes water retention and worsens the congestive heart failure. This is a bad cycle to be in. So that's why we give these people ACE inhibitors, because ACE inhibitors break this cycle and stop the aldosterone production. And not only cause vasodilation, which reduces your sympathetic outflow, reduces your actual afloat effects, but also decreases the actual uptake of reuptake of more fluids. When I first saw my first congestive heart failure patient, it's nothing like you'll ever see nowadays. We had the guy came in to the clinic. He'd been sick for about 3 years, and we looked at his legs, and his actual legs were overlapping over his ankles. The skin of his legs were overlapping. You could not see his ankles. It actually looked like an elephant walking in. Okay, you could only see his toes, and that was it. Okay, all of it was peripheral edema. Okay, he had over 40 pounds of extra fluid on board. We did not have ACE inhibitors at that point. We did not have really loop diuretics at that point, that many of them. Okay, and this guy came in for a new treatment, which was Lasix. You know, you guys get Lasix every day. It's like a big deal. So we gave this guy Lasix, 20 milligrams IV. That was a recommended dose then. Wow. We were going like, Wow. He kept peeing liters, liters, and liters. In literally 4.5 hours, he put out 28 liters. We were waiting for this guy to die. We were checking his blood pressures. Well, where is this fluid coming from? And literally within the next 3 days, as we kept giving him more and more Lasix, okay, his ankles went down so you can actually see them again. And it was very impressive. We lost 40 kilos in that patient in about 4 days. So we lost 40 liters of fluid in this guy. So it's pretty impressive. That's a hell of a diet plan. Lose 40 kilos in 3 days. What's more interesting is the guy never dropped his heart. It's actually his blood pressure went up over time. He actually, his heart must have gotten smaller, gotten more efficient as we gave him the diuretics. And he went from being severely short of breath to now actually breathing fine. He actually could walk out of the hospital. It was a rather interesting thing. It was a new medication then. So that's how much things have changed. Yes? This one occurs more in late. The ANF normally will kick in initially to hold you from going into failure. But ANF will shut down when you become chronic. So that actually makes the disease progressing faster. Okay. Renin is almost dominant from the beginning. Renin is an indicator of decreased perfusion to the kidney, which is a first sign of failure anyways. So the kidney gets activated very quickly to release renin and never stops producing it until you get renal failure, okay, which is very, very late down the road. Now, what you see with left ventricular failure that's different from right is that you get dyspnea, you get increased work of breathing because of increased fluid in the lung. You can actually see how bad it is by quantitating by exercise tolerance. These people have very limited exercise tolerance. Orthopnea is because the person, when you lay them down, they get fluid shift from the lower extremities up to the lungs, and they develop a dry, non-productive cough on recumbency, which is usually pathognomonic for pulmonary edema. That's early. Manifestations of chest x-ray. This is a person that was treated with diuretics and improved, but this is what they presented with initially. Okay, what you look at in the first stage, 1 of congestive heart failure, you get redistribution in the pulmonary blood vessels. So you see enlargement here. These are pulmonary blood vessels that are becoming more prominent. You get peribronchial cuffing, which you can't really see on these, but up here you can see it up here. You can see those the bronchioles are inside here. Right there, you see the peribronchial cuffing in there. Right here. That's peribronchial cuffing. And you also see what's called curly B lines. Okay? Curly B lines are indicating to you that the person is also developing failure, which is the curly lines, which is in stage 2. And then you go into stage 3, which is where you actually get consolidation and you get pleural effusions. Okay? This individual, you can see over here, has developed a pleural effusion. Okay? So congestive heart failure is treatable, but eventually some of the fluid will get out into the pleura and will develop pleural effusions on you. And you see it's dependent. You see, if you look at the lung, where's all the volume? It's gravity dependent. So as the person fills up with more and more fluid, their lungs become more and more white, because it's an indicator of how much fluid's in the lungs. Okay. What you see is on exam is you get Ralls on auscultation, and you'll get a third heart sound, which is pathognomonic of left ventricular heart failure. So an S3 heart sound is an indicator of CHF. Okay, and you need to memorize that. The other thing you will get is PND, which is paroxysmal nocturnal dyspnea, which is shortness of breath when the patient wakes up in the middle of the night with sleeping. Most of these people don't develop this because most of them don't sleep lying down anymore. They sleep in a chair. Usually they'll tell you that I haven't slept in a bed for the last 6 months or a year, because every time I do, I don't wake up very comfortably. I feel like I can't breathe. That's PND. If you're not careful, the person may go into acute cardiac pulmonary edema, which indicates to you that the PA pressures are greater than usually 30 millimeters of mercury, and the lungs are starting to fill up with water very quickly. And it's usually an indicator of mitral valve incompetence, which you get a very large V wave. So what does that mean? This is you're not quite normal. This is a person with mitral regurgitation that's very mild, This is what I would consider at a very early stage of congestive heart failure. The mitral valve becomes incompetent because of the increased volume in the left ventricle, which then puts dilation effects on the annulus. It also will cause ischemia of the papillary muscles, which increases the risk of developing MR. And as a consequence, you get this enlarged V wave. This is mild, and the person would be hardly asymptomatic at this point. As the disease progresses, what will happen is the PA pressures will begin to rise simply because you're getting more regurgitant volume back through the actual mitral valve, so you get very large V waves. And then if you get into a complete acute pulmonary edema, let's say from hypertensive crisis or something like that, then you get something like this, okay, where you get rapid large V waves that now are equal to, in height, to the systolic pressures. So this begins to mimic almost like the ventricular waveforms. The reason that's such a serious effect is that when you look at your PA occlusion pressure, you'll see the large V waves, which is what you see down the bottom. But if you look at the PA pressures, you'll see something like this on your PA waveform. Okay, so you get this secondary peaking because of that extra waveform of generated pressure. So that's how you pick up as somebody that has ischemia or developing left ventricular failure. So you go from having a PA waveform that looks like this, that's your PA pressure, and then all of a sudden it starts doing this, and then when it gets really bad, it looks like that. It's a worsening disease process. So when anybody's ever told you that if you're looking for left ventricular failure, and they tell you, oh, you can actually see it in the PA waveform, how many of you knew that? Yeah, that's what I thought. Okay, that's sad. Okay, but that's what you're looking at. When you're looking at PA pressures, what you're looking for is a secondary hump. What looks like the diastolic pressure, the diastolic pressure, because that's where the pulmonic valve closes, is right here. People don't understand what you're looking at here is that's the actual ventricle still firing on the left side. Okay, and that pressure is being generated as a consequence, which gives you large V waves. Okay? So one of these days you'll see this. Where you see this all the time is in open hearts. So you know that I'm not relying. When you go to open hearts, the ventricle is already in failure to a certain point when you're coming off bypass. Look at the PA waveform, and you'll see almost every one of them have this issue. And within 10 minutes, when the valve, when the myocardium begins to warm up again, and it also develops more oxygenation because of the improved coronaries, then this will go back down to normal and come back to here. So it rapidly does it in less than 10 minutes. So then the valve becomes more competent. And you look under TEE, you actually will see the MR is pretty prominent, and then it goes away because the papillary muscles begin to function again. So this is what the person will look like. You get jugular venous distension, infarct. This is all the different kind of things you'll see. Okay, this is for biventricular failure, not just left ventricular failure. Jugular venous distension usually is not seen until you go to right-sided heart failure, which we'll talk about next. So what are the manifestations of right heart failure? And the answer is you get systemic venous congestion, which is elevated JVD, which is jugular venous distension. And the way you should do JVD is you should lay the person completely flat first, okay? And then what you want to do is you want to bring the bed up to the point where you actually see the internal jugular vein fall to the point of the sternum. And you can actually measure the height of that. Normal is about 15 degrees. It should be more than enough before the person actually it goes completely away. They've got this person way up at 45 degrees, which means that their PA pressures, the jugular venous pressures must be sky high for that to completely drop back down. But in normal circumstances, about 15 to 25 degrees should be more than enough to see it go away. If you see your internal jugular vein is obviously when you're standing up, where you actually see it moving up and down, that person is in right heart failure. Okay? It is actually the easiest central line you will ever put in because the vein is huge, even throughout the whole cycle. So it's actually very easy to put a central line in these people. What you eventually see when the right heart fails is everything behind the right ventricle, which is a tricuspid valve, right atrium, superior vena cava, inferior vena cava, begins to increase in volume. Okay? Because of that, you get organomegaly. The liver gets congested with fluids. Your internal jugular vein gets enlarged, and your perfusion out of your brain decreases. So sometimes it can cause confusion. Most people take that confusion and make it go away by sitting up. Okay? The lungs, when you listen to them, sound completely dry. If it's isolated right ventricular failure, the lungs are completely dry. Okay, so you get no desaturation really. You get the lungs don't sound of any rales. There's no S3. It's purely just clean lungs. And that's really important. And so you separate the right ventricle from left-sided failure. But the most common cause of right-sided failure is left-sided failure. So usually you get both things going on. So if you see elevated JVD and you hear wet lungs, what do you have? You have both. You have left ventricular failure with right ventricular failure. Okay? If you do have isolated right ventricular failure or combined, you get portal congestion, ascites, varices can develop, and peripheral edema is usually a prominent sign. So organomegaly, one of the things that will happen from the liver congestion is that it will cause elevated prothrombin time, okay, which then causes an increased risk for bleeding, and it makes regional anesthesia not a good idea in that sense, because the person may be at high risk for developing spinal hematomas and stuff like that. Peripheral edema is usually dependent, and you get pitting edema develop. Treatment of this congestive heart failure is simple. You got to look at it from all 4 points: heart rate, preload, afterload, contractility. You're going to want to reduce your afterload as much as you can. So treat hypertension. Usually ACE inhibitors are a primary treatment plan for this, or direct vasodilators. The downside to ACE inhibitors and direct vasodilators is they may cause reflex tachycardia, which is something you may not necessarily want to have. Preload reduction is a critical part of this, especially if you have left-sided heart failure. Giving them preload reduction can be life-saving. So diuretics, usually loop diuretics, are primary agents of choice. You don't want to give them mannitol, because mannitol will actually increase your preload initially and then cause a decrease. So you can actually push a person in failure that's already in it, already really way into it, so you don't want to do that. But loop diuretics in that case are pretty safe. Increased contractility, usually using digoxin or some kind of agent that increases inotropy. And you can also decrease your myocardial workload once the person's stable with beta blockers. And some people will actually use calcium channel blockers, which can also act as afterload reducers. And heart rate depends on the situation. You either want to slow it down or make it more rapid, depending on the situation you're in. If you're in acute congestive heart failure, I would tell you leave the heart rate alone. Don't mess with it. If you're already in a chronic state where the person's stable, reducing workload is actually a good idea. So what increases contractility? The agent of choice is digitalis. It's been used for many, many years. Now we're starting to use more dobutamine. Sometimes they're giving it intravenously for long-term treatment plans of people as well. Decreases in preload with nitrates or diuretics, decreasing your afterload through arterial vasodilation, which is the ACE inhibitors. The calcium channels are really getting investigated because they're thought also to possibly mediate or inhibit some of the vasodilation effects that not the vasodilation, but the remodeling effects of the heart. And also our direct arterial vasodilators can also be considered. The only downside to most of the direct arterial vasodilators is that they cause a reflex tachycardia to take place in all these patients. And heart rate for chronic therapies, beta blockers, pretty much a long-standing treatment plan. Pharmacological treatments for digitalis, what it basically does is it inhibits the sodium-potassium ATP pump. When it does that, it leaves residual sodium inside the cell. It also increases the actual levels of intracellular calcium, and as a consequence, increases contractility. Okay, so it increases inotropy. It's a positive inotropic agent. It does appear to have a qualitative effect of decreasing cardiac size, because it is able to effectively empty the ventricle more efficiently and increases cardiac output. And the downside to it is that DIG is one of those dangerous drugs that used to be used as a poison. DIG comes from actually a plant. It's a very pretty plant, which I'll show you a picture of in a minute. But the downside to it is that it's cleared by the kidney. And what's the number one problem that you have with failure? Inadequate renal perfusion. So if you don't get good perfusion of the kidney, then you get decreased impairment of DIG, which then causes DIG toxicity to develop pretty quickly. This is digitalis, the actual plant. They actually have one in my yard. It's actually It's a very pretty plant, except you've got to keep all the kids away from it because it will kill kids and animals, so don't let them eat the digitalis plant. It used to be considered a poison. It's prophylactic for atrial fibrillation and not something we normally discontinue when we do open heart surgery. We actually keep it going because we know it's protective, preventing atrial fib from going into rapid SVT. The downside to it is that toxicity-wise, it's more prone to develop in hypokalemia, hypercalcemic states, and hypomagnesemia states, which is pretty much what's going to happen in open hearts. And arterial hypoxemia can also predispose to toxicity. What these people usually with signs of toxicity is they get anorexia, nausea, and they see a yellow halo around around you. So you ask them, said, "Do you see a halo around me?" And they'll sort of laugh and say, "No, you're not an angel." So that's fine, okay? That means you're not ditch toxic. But if sometimes I've had one person actually look at me and says, "How do you know?" I've never told anybody that. So, oh, okay. How long that's been going on? And he goes, "Well, it's been the last 2 or 3 days." I said, "Well, okay." So then you look for it, and it's actually ditch toxic the person's in. And it's not because you become an angel of mercy at that point, okay? What you want to look for in ditch toxicity is you want to look in the EKG. The EKG normally will show very scooped ST segments, which is what this individual had, okay? And they thought the guy was having NMI when I showed him, and especially the person was in ditch toxic levels. Doing a plasma level is a waste of time and money, so we don't do them anymore. Instead, we begin to treat them symptomatically. Usually the best thing to do is hold the dig and then correct some of the predisposing factors, which is don't allow the person to be hypokalemic, which is the most common, so reversing the hypokalemia is kind of important. Drugs that you'll treat for different kinds of arrhythmias include lidocaine, phenytoin, and atropine. Atropine for slow bradycardic events, which is what you tend to see with the dig. I wouldn't be pushing it if the person has no signs of hypotension or anything like that, so I leave them alone. Consider having a pacemaker readily available, and then you can have Digibind. Digibind is an antibody that actually binds to the digoxin. The only downside to that is extremely expensive, so most hospitals don't necessarily have these in formulary readily available. Really, if you have dig toxic, you basically should cancel the surgery, which is what we did with this individual. This person got put in the ICU, corrected their potassium, which was 2.9, and the person corrected pretty quickly, and then 3 days later, he basically went and had his elective surgery. By that point, his halo effect had gone away. It's like I felt like, oh, well, I'm no longer an angel. Oh, well. Proceed with emergency surgery. Avoid ketamine, sympathetic nerves, and hyperventilation. Hyperventilation because why? It drops your potassium levels quickly, so you've got to be careful with that. Treatment, again, reverse hypokalemia. Particular debility is usually lidocaine because lidocaine is a rapid sodium channel, so it affects the rapid sodium channels. And for that reason, lidocaine is treated for that. Supraventricular arrhythmias, you give phenytoin, and bradycardia, of course, is atropine or temporary pacemaker, and of course, your Digibind. Now, if a patient comes in with acute congestive heart failure and you need to take him to surgery, the things you want to consider is giving that person immediately oxygen. Morphine is also helpful because it's a preload reducer. It also decreases stress response, so it decreases sympathetic output and will slow down the heart rate a little bit. Beta agonist, which in other words, this is not antagonist, which is beta blockers. You're actually going to give beta agonist, something that increases heart rate temporarily to get them out of failure. Usually some of these people present with overdoses of beta blockers and their heart rate's in the 30s or 40s. So you give them something to get their heart rate back up around 60, 65, and everything gets better. The other thing that you consider is giving phosphodiesterase inhibitors, which can give IV, which then drives your contractility up. Or what I personally like to use is CPAP. Okay, CPAP is continuous positive airway pressure. It's administered through a mask to the individual, so you don't necessarily have to re-intubate the patient. The benefits of this is that you maintain the constant pressures, and the ventricle gets squeezed around the outside downwards. When you do that, the ventricle remodels itself to a better functional state on the Starling's curve, and then you actually increase the contractility as a consequence. The downside to it is that the preload does drop, which is what you want, and if it's done appropriately, it actually improves the forward cardiac output, and then you actually get a more effective diuresing. The downside to it is that some people are still pumping fluids in these people at that point, which is really a mistake. If the person's in failure, that means their preload is more than adequate, and actually they're usually overloaded. So go to KVO, shut down your meds, and shut down your fluids, and then give them this, and then give them Lasix. If you do Lasix and CPAP, within 45 minutes, usually the symptoms go away. Then you can wean off the CPAP, and all of a sudden the patient is actually healed. So CPAP is actually a therapeutic modality that it actually works pretty well. Now, if you have patients in the presence of surgery, what do? If the person has acute congestive heart failure, the case is canceled, period. Okay? If the person has an acute event where you have to go, no matter what, like in so you have open heart surgery, the risk goes way up, okay, even though you're going in there to fix the problem. Just understand that that person is not for a rapid extubation phase. That person's going to stay intubated for a few days, most likely. So I would not take anybody back with acute congestive heart failure unless I'm totally forced into doing it, okay? And knowing that the mortality rate goes up by about threefold. It's pretty bad, okay? And what everybody will blame you is, of course, that the MI progressed because they were under anesthesia. Yeah, right, okay? So you sort of don't get caught in a bad place. In other words, if somebody has an S3 gallop and they have pulmonary edema and they're going for elective surgery, no, they're canceled. They're done. You send that guy, call the cardiologist, don't even let the patient leave. Call the cardiologist, tell them to come down, check the patient out, and put the patient in the hospital and get them treated. As for chronic congestive heart failure, you need to try to optimize them medically as much as you can. What drives me a little bit crazy is that sometimes they make them so dry that they make them into popcorn. You know, they're just completely dehydrated. So you put them under positive pressure ventilation, and they completely fall apart on you. So there's a sort of happy medium. Which one's safer? Is it general anesthesia safer or regional anesthesia? And the answer is they're both dangerous. Okay, no matter what you do to these people, bad things will happen. They have a higher incidence of complications and risk. If you let the person go into general anesthesia and you don't let them spontaneously breathe during the case, there's a lot of times because you're giving the positive pressure, you're preload reducing them acutely, and you're going to have to give them more fluids. So usually they actually get better with positive pressure ventilation initially, but then when you wean them off at the end of the case, that's when they go into fluid pulmonary edema on you, right at the end of the case. When everything's fine, you go like, I did this great case, and then you let them spontaneously breathe, and all of a sudden you're in trouble again. If that happens to you, put them back on positive pressure ventilation, give them Lasix, dry them up, and then try again. Most of the time what we usually do is we'll put them in the recovery room intubated or on CPAP mask. If we got them extubated before we realized that they were in edema, get them on CPAP or BiPAP, whichever one you want to do, I don't care, and then give them Lasix, dry them out, and usually about 45 minutes you got a perfectly viable patient, and off you go to the next stage. Make sure you get your MB fractions later on. Make sure that the person has an NMI during the case as well. Regional anesthesia, though, the problem is not so much in the room. Because one of the things that you'll do as soon as you put a spinal in is that they'll vasodilate. So their preload will fall. And then what do? Especially when they're dry like popcorn, right? You're going to give volume. You're going to give a liter, 2 liters of fluid, and you go like, oh, this was fine. This is great. Because everybody else that you take care of that's 25 years old, and you give them 2 liters, nothing happens. Well, these people are already on the edge of the compliance curve. They have nowhere to go. Okay? So you take them to recovery room, you drop them off the recovery room nurse, and you go, see ya! And you start running out of there as fast as you can. Okay? The reason you're running as fast as you can is because they go into failure not when you're care, because the spinal's still working. It's when the poor nurses in the recovery room start seeing that the sympathectomy goes away. Okay, so 45 minutes or 2, depending on which spinal you're talking about. If it's actually bupivacaine spinal, it could be 3 to 4 hours down the road. Then you'll get a phone call. This guy's desaturating. Yeah, and the answer is yep. And what do? CPAP, Lasix, same treatment. Okay, so either way you go, you just have to anticipate when the danger spot's going to be. If you do general, it's going to be right usually at the extubation point. If you do regional, it's going to be in recovery room 2 to 3 hours into recovery phase. But you can't let those patients go upstairs. That's the trick. If somebody has got this borderline congestive heart failure and you decide to do a regional, then that person cannot leave your presence or leave your care for at least 3 to 4 hours after the procedure is done.